former students and former colleagues, and it's a real delight to be here. I have been associated with the Institute for Life Course and Aging for 18 years now, and it's really my home outside of social work. I really feel like this is my academic home because there's so many interesting things going on. I guess I need to justify why, as a gerontologist, I'm talking about early life experiences. And I'm coming from a social work perspective, so I'm looking at the individual in their family and community context. And the more things I looked at, I often look at health outcomes, I couldn't explain a whole lot when I was just looking at their immediate context. So I thought, well, maybe I need to go back a little bit farther in their lives, you know, because the impact on health is cumulative. And so I went back to pre-retirement. And then I kept on going back and back, and ended up in childhood. And it isn't that surprising that the early experiences really form who you are and how you react to stress and your later life experiences and what options you have later in life. So I come from a social determinants of health perspective. I'm a closet social epidemiologist. And it just seemed I needed to really think farther back. And in fact, I'm starting to now think prenatally as well, what was going on in the family of origin before the now 70-year-olds who developed a stroke existed. And I won't reflect that research because that's still emerging, but at least I've got back to early life experiences. So I've been working in this area. I think our first publication came out in about 2009. I've been thinking about it since about 2007, 2008, since some of you were students with us. So you've seen my thoughts on this area emerge. And I have to say, I have been influenced by my students and my colleagues who are working in child welfare, and doctoral students as well. So just looking at early adversities and sexual abuse and physical abuse and thinking about the incredible chaos of that home environment and its immediate impact on health, it made sense that there was also a long-term impact. So that's partly where I'm coming from right now. Okay, let me just see if I can figure out page down. Page down, okay, got it. Okay, so what I'm going to go over today in about an hour are some of the previous studies on childhood adversities and health, potential pathways linking early adversities to health, and a description of the Canadian and U.S. data sets that I've used. Hi, welcome. Welcome. And findings on 10 health outcomes that I've looked at. And a brief work, I've just started to look at other childhood adversities as well. Most of my work has been on childhood physical abuse, but I've looked at childhood sexual abuse. I've also, I'm just starting to look at verbal abuse. What does being put down by your parent, even if in the context of not being physically or sexually abused, what does that do to you? And also at parental divorce, which has been hugely studied with respect to mental health outcomes, but we're only beginning to do the work on physical health outcomes, potentially of parental divorce. I'm also really interested, and I'll draw your attention as we go along, that there seems to be different physiological mechanisms for women and for men. So the stressors may not react, the early stressors may not be associated with an outcome in women, but are in men, and vice versa. So most of the studies, if I had sufficient sample size, I would have divided them, because I think a lot of the research would be cloaked by a neutral response and a positive response. It looks like you have a neutral response if you put them together. And I'll talk briefly what other researchers have been doing in a very exciting work on biological embedding. How do these early adversities actually get under your skin and cause or influence health outcomes? But again, that's not from my own research, because I'm a social scientist out of a social work tradition, so I'm usually looking at the individual in their context and not looking internally at their biomarkers and stuff. And then I'm more than happy to take questions. If things aren't clear, or if I'm not speaking well enough, please just stop me as we go along. Okay? So, Mid-1980s. I'm a newly minted social worker. So excited. I got my first practice job, and it was an unbelievable job to get out of a BSW. I had voluntary clients. Usually social work clients aren't really keen to see them. But I was working in a women's health collective in Montreal called Head and Hands. And we all made the same amount of money. It was a pittance, but everybody from the lawyer to the director to the social workers to the secretaries, we all made the same amount of money. We made all decisions communally. We had 3-hour meetings. My husband's a little more task-oriented, and he's like 3-hour meetings every week to decide everything from what programs we were going to offer to what color the wall should be. That was in the mid-'80s when incest had been discovered. People had not been talking about incest before. And so I had voluntary clients. There was a long wait list. People could come and see us for free. There was 2 social workers on staff. And more than half of my clients were adult survivors of childhood sexual abuse who had never disclosed before because it had been such a taboo topic that nobody was saying anything about it. And my clients had a range of physical health concerns. They had, type 2 diabetes, arthritis, heart problems, high blood pressure. They had all kinds of things. And I would love to say that I had this eureka moment that said, oh, early childhood adversity must be associated with adult health. But there was just way too much noise in the data. It wasn't like they were all coming with the same issue. There was all kinds of health issues. So I did not have a eureka moment. But luckily, this fellow, Vince Fuller-Thomson, had that eureka moment. So he is a physician who specializes in severe weight loss programs for people who are morbidly obese, people who are 400 pounds, 500 pounds. He helps them lose weight non-surgically and has super success in bringing down over 100 pounds a year or 200 pounds a year. And he kept on seeing that people would get their weight down, primarily women in his practice, and then they'd sabotage themselves. All of a sudden, they'd start eating, and their weight would go up. And so he figured he needed to find out psychologically what was going on because his physical or diet interventions were working very effectively, but something went wrong. And typically he found that many of the people presenting talked about having been sexually abused as children. And they used weight as a cloak to make themselves less attractive, less vulnerable. So it was a self-soothing behavior, but also it was a protective behavior. So as they started to lose weight and a guy would hit on them, it brought back all of this early panic, and they started to put on weight, 40 pounds in a month. It's almost physiologically impossible to do that. I mean, you just to put the cloak back on. So he started to think that there was something profound, and he did a little survey with his population and found very, very high rates of child abuse, particularly sexual abuse. So he was presenting this at a medical conference, and luckily for all of us in the field, Mike Anda, who is an epidemiologist from the Center for Disease Control, was in the audience. And he said, well, that's a really interesting idea, but you can't go to say anything if you've got a sample of 100 people and you see this little connection. We've got to do a really good study. And so they did this really good study. This is really the seminal work. Well, I wanted to point out it. But anyway, that had over 9,000 people. So Vince Fuller-Thomson works in a health maintenance organization, the biggest in the U.S., called Kaiser Permanente in California. So it tends to be all working people, middle class and upper middle class in it. So it's not a representative sample, but he had a very large sample, and he had this questionnaire that he sent out about early childhood adversities, and he looked for a whole bunch of adversities, which included verbal abuse, physical abuse, sexual abuse. This is before they left home, so age 18 and under. Parental divorce, violence against the mother, family member with substance abusers, addicted to drugs and alcohol, mentally ill parents, suicidal parents, ever imprisoned parents. And he put all these questions in, and he found a dose response. So when we're talking about dose response, which means it's a stepwise, every single additional type of adversity you had was associated with almost every disease in the book. They had great data because it was connected to the medical records, so they knew almost every disease. with respect to cancer, with respect to heart disease, with respect to almost everything. There was this dose response. Every additional stressor, your risk of the disease went up. So you could almost change the outcome and you still have the same graph, you just changed the name on the outcome. So here he looked at heart disease, cancer, stroke, diabetes, hepatitis, skeletal fractures, everything. And so this finding was particularly profound. He found that if you had 6 or more of these adversities, in other words, your home life was absolutely chaotic when you were growing up, all of these negative things were going on, you died on average 20 years earlier than those with 0 ACEs. With ACEs are adverse childhood experiences. 20 years, this is more than the difference that eradicating cancer would make. This is a huge, huge difference. Now remember, he was only looking at people who were already adults. Like, you had to be 18 to get there. So these kids, it's not as though these kids were so badly abused that they didn't live to adulthood. This is the long-term outcomes of these early adversities on people who survived to adulthood. So Vince Felidi's done all this interesting work and typically has looked at the outcomes cumulatively, how many of these adversities you had. Coming from social work, I thought for my students and the people in the field, it's helpful to know what seems to be associated with physical abuse, what seems to be associated with sexual abuse, because those are the populations. People aren't working with a cumulative picture, they're working with one particular outcome. So my contribution has been to kind of divide it and parse out, looking at what kind of outcomes are associated with each adversity, and also to use representative population-based data. This data is fabulous, but because it includes only people that are part of a health maintenance organization, it doesn't necessarily address the whole broad spectrum of society, while a population-based community representative sample does. So that's where I was coming in. I'll be coming in. So Goodwin and Stein did move the field forward, looking at a national comorbidity study. So again, a nationally representative study in 2004. Oh, Felidi's first work is in 1998, and they've been publishing from that and subsequent surveys in the similar populations for the last, since then, almost 15 years, I guess it is now. But Goodwin and Stein brought it to a representative population, and she found that childhood physical abuse was associated with lung disease, peptic ulcers, and arthritis. And they could control, which means to adjust statistically to take into account characteristics that were of demographics, for example, age and sex, race, lifetime depression and anxiety disorders, and lifetime alcohol and substance dependence. And still, after all those adjustments, the childhood physical abuse was associated with these outcomes. Now, Springer did a study in 2007, which was also very influential, with the Wisconsin longitudinal study. So this is a fascinating study of high school graduates in 1957. I think they interviewed every high school graduate in Wisconsin, and then they followed them up into the 2000s. So we have a nice long-term outcome with a representative sample. And they found, and I've just listed them alphabetically, but you can see we kind of cover most of the major forms of chronic illness. Childhood physical abuse was associated with allergy, arthritis, asthma, circulation problems, high blood pressure, heart troubles, and peptic ulcers. They could control for, or adjust statistically, for age, sex, family background, and other childhood adversities. So this is not a rhetorical question. What might explain the link between early adversities and health? Any takers?
Well, we store tension in our body, and that has effect on our health in all sorts
Sort
of
of the
ways.
mind-body continuum, that we internalize the stressors.
And particularly if we block memories of things or deny them, I think it has more effect.
Okay, so repressing is even more internalizing. Okay, I didn't go, in fact, I think you're probably very right, and we'll get to that at the end. I wanted to find something easier to adjust for statistically, and that wasn't. Yes.
Maybe parents not being conscientious to bring the kids in for regular
Okay.
healthcare visits?
So it may be a deficit in basic care in childhood and getting your shots and all of those things. That's a possibility, yes?
Perhaps an increase in risk-taking behavior.
Okay, so what kind of risk-taking behavior are you concerned with?
Well, just, I don't know, because on one of the slides you mentioned skeletal fractures.
Yeah.
So more like going out, doing high-risk activities.
Okay, so possibly taking a variety of risks in life, and we'll get on to different types of risks that certainly are associated. Any other takers? Yeah.
Household income?
Yes. Okay, so this is an excellent point. If children are in an abusive or dysfunctional home environment, they're more likely to drop out of school and leave home early because it's not a nice place to be. And if you've dropped out before the end of high school, the trajectory is not good. So you tend to be poor, and poverty is very highly associated with almost every disorder, except breast cancer, perhaps, but almost every other disorder. And poorer people don't get breast cancer as much, but they tend to die from it if they get it. It tends to be diagnosed later. But almost every other disorder, you have a stepwise between poverty and the disease. As you get richer, you tend to have less of the disease. Okay.
Esme, is it, or could it be that that's all they know? So and they just ignore things, okay? So if I, for example, if I start coughing, I'll automatically go to a doctor. But if I've been kind of physically or emotionally abused, that's the way life is. And you don't complain, you don't go and see anything, you don't go and do anything. So that's just the way it is. And so by the time a doctor sees them, by the time the specialist sees them, it's already set. Whatever it is, the asthma, and you're saying about fractures. When you said that, I thought early nutrition, because bones will break very easily if the physical body has not been nutritionally aided. But I just wonder if that's just the way it is, because I've seen in my class that's the way it is. So why would you complain until it's almost too late to complain, and then they're given a prognosis of 6 months?
Okay, so I think you've given us two issues. One is early nutrition. In a neglect situation, it might also be neglect with respect to food and milk and calcium and all these other sorts of basic nutrients.
Almost survival skills. A lack of understanding of survival skills.
Okay, and the second issue is about inadequate self-care in the context that they didn't feel proactive about preventive care because they hadn't been cared for. Yeah.
Well, just
Rachel?
with the care, these were American studies.
Many of them were American.
Very hard to get
Yeah.
to the doctor if you have the economic issues. It's hard sometimes if no one has reported abuse, so there was no intervention because the doctor didn't report and maybe a teacher didn't report, so there was no intervention. So exactly as you said, they thought that's the way it has to be.
Okay, great. I'm going to give you an example. I tried to get one that wasn't it wasn't too traumatic to listen to. It's still upsetting, but this is a woman who has come forth about her early adversity, her early abuse, because there was laws before the court in this particular state. It must be, maybe it's Texas or something, that to toughen child abuse laws. Okay.
This horrifically.
But there were days, Sheldon says, she knew a beating was coming.
Most often I would see it in his eyes first, and then his whole demeanor would change. And I knew at that time that it was get out of the room or be trapped.
She would take shelter in the woods.
My brother and I sometimes would have to escape in the middle of the night, go out a back door, in our pajamas, in the freezing cold.
Later as an adult, Shelton became an alcoholic and drug addict. She would also cut herself to relieve the emotional pain. At one point, turned suicidal. She's sharing her story as lawmakers tried to stiffen penalties.
So this was the risk-taking behaviors that I was looking for a little bit, because smoking and drinking can be associated with self-protective, that just to pull down the anxiety, people can search out what turns out to be long-term unhealthy strategies. Okay, so I think you got to most of these. We're going to go in more detail. So possibly, the one we didn't talk about, we talked about other childhood nutrition, but it's usually how many of you have a child welfare background? Anybody? Yeah, okay. So it's child physical abuse rarely happens solely. There's other stuff going on. Neglect, parental addictions, chaotic home environment, long-term unemployment, poverty, there's all these other issues. So the question is it really physical abuse, or is it really a cluster of these risk factors that seem to be associated? Then we've talked about health behaviors, and we'll spend more time on that. Socioeconomic factors. Now marital status. People who have adverse childhoods, including being abused, are more likely to become divorced. And being married is quite protective for your health, particularly for men. For women, being in a happy marriage is very protective. For men, it appears any marriage is somewhat protective to send them off to I think partly because health-seeking behavior, it tends to be prompted by a wife. You know, like you basically have to be bleeding before you go to the doctor otherwise. But preventive kind of health care tends to be, those appointments tend to be made, or partner. So, but there's also the social support, social network kind of issues that go on through marital status. And mental health, depression and anxiety, which I have a little bit studied it. I'm not really focusing on in this presentation because those are self-evident, that early adversity makes one more vulnerable. Lots of people don't succumb to depression or anxiety, or post-traumatic stress disorders, but that link is fairly clear to most of the general public. Yes,
What
Rachel?
about the cycle of abuse? If you were abused as a child in a marital situation, you may often find an abusive relationship as well. And then it goes to the next generation.
Yeah, you're talking about getting yourself into a
Yeah.
dysfunctional
Yeah, right.
position. In fact, I was going to do a variety of different people speaking, and one of the women said, you know, this is why I chose unhealthy relationships, because I didn't, you get the love you deserve kind of idea, and I chose wrong because I was grasping at something. And it was, this particular commenter said, but she was being interviewed by her daughter, who put it up on YouTube. And she said, but you know, you and your brother are the biggest blessing, even though the relationship itself ended up being very hurtful. So we talked about childhood physical abuse tends to occur concurrently with other adverse childhood experiences. Not in all cases, but chaotic families often have a few of these going on. So we've got parental addictions, parental conflict and divorce, household poverty, parental long-term unemployment, and it may be this convergence that's an issue. So, where am I going? Oh yeah, just a sec. So, believe it or not, the World Health Organization does not recommend universal screening for childhood physical abuse or childhood sexual abuse. In fact, they recommend against it. Any reason why? Could you guess?
Politics?
Possibly, but that's not their public justification for it. They actually are concerned about something that's technically called false positives. Abuse, luckily, is still a relatively rare occasion. So if you have universal screening, if every pediatrician screened every child on every time they were there, you will have incorrectly screened individuals, and the child and the family can be traumatized by an inappropriately activated screening. And also it would totally overwhelm the child welfare system, so that they wouldn't necessarily be able to work with the most acute cases because they're overwhelmed by implausibly low numbers of correct referrals. So my natural inclination is screen everybody, but I understand what they're saying. So the idea is, if you get a higher risk group and you do your screening in a higher risk group, the chances of false positives go down. So if it's a really rare occasion, then you're going to have, depending on the sensitivity and specificity of your test, you're going to have more incorrect guesses. But if you can imagine, just think about it, if 100% of the group was affected, you're not going to have any incorrect referrals if you're screening. So here's what we found. So these are Canadians, adults, a representative sample, and they reported about their childhood experiences. So they reported on 4 things. Whether their parents were addicted to drugs or alcohol to a point that it caused problems for the family. Whether the parent was unemployed for a period of 6 months or more while they wanted to work. So we're not talking at-home moms. We're talking about parents who were actually seeking work and could not find it, which can be a marker of level of addictions problems, potentially, right? There could be something else, or mental health issues, but it could also be just where they're living. Then we've got parental divorce. And then they were also asked if they were physically abused as a child. So if they didn't have any of those first 3, no parental addiction, no parental unemployment, and no parental divorce, the 1995 study that we looked at, this is a Canadian Community Health Survey, indicated about 3.4% reported that they'd been physically abused. So a relatively rare occasion. Let's just go down to 1995. I'll tell you the logic. I've never seen a difference this big in my life. That's more than a 10-fold difference. So I have a tendency not to believe it. When there's something this big, when you're going to say something like this, you want to have replication. So the true social science and sciences is that everything should be able to be replicated. Somebody else should find the same thing with a different representative sample. I was too nervous to publish this until I checked it out myself, because that's just such a bizarrely big number. I expected it to be associated, but not a 10-fold plus difference. So I looked at it again in 2005 data, and as you can see, with no risk factors, I found exactly the same. So that each samples, 2005 is, I think, about 13,000 Canadians, both from Manitoba and Saskatchewan, a representative community sample. 1995 is about 18 or 19,000 Canadians, a national sample. But we found the same thing with respect to no risk factors. If there was only one risk factor, so only parental addictions, or only parental unemployment, or only parental divorce, it went up markedly, for around 13%, somewhere around there. Now, by the way, that's largely driven by parental addictions. Parental addictions is really up at 18, 19%, and the other ones are more 8, 7, 8. So it's driven by that one type. If there was 2 risk factors, in 1995, we found about 25% of the sample, so a quarter of the sample reported that they were physically abused. And in 2005, we found 30% of the sample, so there's a bit of difference here. But if we found all 3 risk factors, we have 41% in one sample and 36%. So that's probably random variation, but you can see that 10-fold numbers hold. So our paper that we were published, I did it with Jamie Sawyer, who's a doctoral candidate in our program. Our paper, we said, wait a second, if you don't want to do universal screening because of false positives, let's wait to get 2 risk factors, and then automatically, this type of information, the average pediatrician might well know that there's parental addiction, parental unemployment, parental divorce in the household. So maybe when you have 2 of these factors, that should trigger a screening. Not a full-out investigation, but just a screening, that should be part of it. So that's what we recommended. I just want to talk a little bit about this difference. We're trying to figure out why that might be so, and we think it might be a cohort difference. By cohort, we mean it might reflect the period in which these parents were born. Can you figure out what might have happened historically? Economics? In particular, we think it's the 1930s depression, because the people who are adults responding in 1995 were more likely to have parents who were adults in the 1930s than the people in 2005. They're younger, right? So their parents were more likely to have been unemployed due to a massive worldwide recession, as opposed to the parents of this group who would have been looking for work in a period in which unemployment was relatively rare. So unemployment, long-term unemployment, may reflect more personal dysfunction in this group of parents than in this group of parents. That's our guess about why that difference made a difference, but we don't know for sure. It's unusual to have a big difference this big in a sample that size. So it must be something different, like a cohort.
What kind of age factor are you looking at?
So the people responding were 18 and up. They could have been anywhere, and it's their parents. So in this group, you can think approximately 30. They had kids at 20. They would have been sort of 38 and up in 1995, the parents, and the parents in this group would have been 38 and up in 2005. So they're more likely to have been seeking work, have lived through as adults the depression in this one. So that's what our guess was.
World War II.
But so you think that, yeah, they would have lived through World War II too. Why? Where are you going with that?
No, they would have to be quite old.
The parents.
You're looking.
Oh, the
Yeah.
parents.
Yeah.
So, so anybody, let's see, so anybody who had a child in 1935, in 1995, the child would have been 60 or about. So a lot of these disorders like heart disease and stroke, that's when you
Right.
start
That's
seeing
why I
it.
asked age group,
Yeah.
yeah.
So that's probably what's going on here. So we're looking at adults, but you don't typically get stroke or heart disease until you're 60 or over, or at least not that you would have been diagnosed by a medical doctor yet with a disorder.
And Esme,
Yes?
just looking in the future, because I'm looking at physical abuse and I'm thinking emotional abuse is just as bad. So in the future, do you think there'll be studies on emotional abuse and especially societal abuse? Because you can see all the bullying and the internet and everything. Is that the way the research is going? Because that's
I actually have
substantial.
a study we're hopefully sending out soon, looking at childhood verbal abuse,
Yeah.
but by parents,
Yeah,
and stroke, and we found an association.
yeah, no question.
But bullying information, typically most of the big national data sets haven't looked, and unfortunately you're looking at retrospective information. So you may, to get to an idea of the severity of that will be a little bit harder retrospectively. It'll probably go there eventually, but nobody's even done a huge amount of work on verbal abuse and physical health outcomes in families, and that's where it should start, and then we can go to societal, community, school
I
level.
think it's really important. I'm 63. I remember kids being physically abused at school by teachers, and it was not funny, and how it has affected their lives. And I think, it's fine, the home situation, and in the same sense, the school situation saved many kids. So I just think that be interesting to see. I don't know if you can ever get a complete picture, but yeah, I'm just looking at physical abuse, and I think it's kind of sad that it's always been about physical.
Well, one of my colleagues, Faye Mishnah, who's the dean of our faculty, is one of the world experts on bullying and its impact. She's looking at contemporaneous sort of being bullied now or in the recent past and its effect. But I think that emerging literature combined with this literature is likely it'll go there eventually. We're not there yet. I mean, I'm surprised how little look there has been even on verbal abuse in the family and its impact. So health behaviors, there's a substantial literature suggesting there's an association between almost all of these early adversities, childhood abuse, sexual abuse, and parental addictions, and your own smoking behavior, your own obesity, your own alcohol use. And we'll talk a little bit more about our own study on this. We looked at abuse and obesity with two doctoral candidates. Sarah Brennenstuhl just defended last month, and she's published 20 of these articles with me, and Deb Sinclair is in our Faculty of Social Work. Sarah did her MSW with us, and she's over in public health. She just finished. So we found, again, we're talking about gender differences. Men, there's no association between childhood physical abuse and adult obesity. For women, there's about 35% higher odds of adult obesity, and I adjusted for everything we just talked about. Your socioeconomic status, your other adversities, your other health behaviors, your marital status, everything I could think of in the kitchen sink that we know is associated with obesity, and abuse still retained the association. So smoking. So this is a paper with Joanne Filippelli, who's a doctoral student in our faculty, and Candace Lou I always have trouble with this, Chrysostomal. She just got married. I knew the Lou part. So we just published that this year. We were looking at 6 types of adversity. So we were using American representative community data there. And we found that to start smoking, when we looked at people who'd ever smoked, that physical abuse, all this in childhood, so physical abuse, parental divorce, sexual abuse, verbal abuse, household drug or alcohol abuse, were all, so that's likely a parent, it could have been an older sibling who was addicted to drugs or alcohol, were all associated with ever smoking in women. And all of these but sexual abuse and verbal abuse were associated with ever smoking in men. So these two factors were not associated with ever smoking, but certainly the physical abuse, the parental divorce, and the household drug and alcohol abuse was associated with ever smoking in men. Now, quitting smoking is something a little bit different because you're physiologically addicted. So the early adversities didn't play as strong a role in predicting who stopped. If I just looked at who had ever smoked, it didn't predict a strong role. But for men, household drug use was significant. So if your parents were addicted to drugs and alcohol, you were less likely to quit smoking if you started smoking. Among females, if you were physically abused, you were less likely to quit smoking. And smoking, even though it's a stimulant, smoking actually has a calming effect, perhaps, and so that it's a self-soothing kind of issue. Did you get it? So there's no literature on childhood physical abuse and inactivity, but because physical inactivity predicts every health outcome I needed to control for it statistically. The couch potato world, eh? Yes?
I have 2 comments from people online. Nat was wondering, in follow-up to the question about historical events, he wondered if the reference to World War II is not an accurate one, given that there would be displacement, job loss, undiagnosed and untreated PTSD, etc., as very key formative factors in numbers of Canadian-born and immigrant families of the time.
So that's an excellent point. So I don't know if everybody can hear that online, but so the point that Susan's relaying from, this is from somebody in Baycrest, okay, is that, or someone somewhere, that building on Rachel's comment about World War II, that we need to think about the disruption that a war and displacement could have on family and family functioning, and so that may also reflect some of the different numbers that are going on, okay?
And Marilyn asked, she asked, has child sexual abuse been looked at in this study? But I'm not sure which one she was referring to when...
Okay, so let me just pop back, and I'll try to, Marilyn, to highlight this as we go on. I'm not doing a huge amount on childhood sexual abuse, but I do report one study. Okay, page up. So the smoking, childhood sexual abuse was associated with ever smoking. So among people, just a representative sample of adults, and they're trying to predict, have you ever smoked? Yes, no. If a woman had been sexually abused in childhood, she was more likely to start smoking. It was not a factor for men. And it did not play a factor in quitting smoking, but what I was saying there is once you're addicted, there's other issues going on than just the early precursors that it's hard to break. Those of you in the room who've quit smoking, it's a challenge, right? Oh, sorry, I think I missed something here. Okay. Did that answer people's questions? If not, just send in another comment. So socioeconomic factors. We talked a little bit about this when you guys came up with the suggestion that we look at this. There's also greater educational difficulties among children who are from chaotic home environments, whether that's a physical abuse or sexual abuse or parental addictions. They've got other things on their mind, and school isn't at the top of it. And there's a decline in, there's some research by Mullen saying that they're typically, in children who've been abused, a decline in socioeconomic status. Most generations at least stay the same or go up relatively, but people who've been exposed to childhood physical abuse are more likely to end up in a socioeconomic strata lower than the one in which they came. Not most, but it's disproportionately likely to occur. This is some research that, it isn't out yet, it's coming out in about Christmas, that I did with Rakshan Mehta, who was one of our Masters in Social Work students, and Angela Vallejo, who is a professor in Ryerson who specializes in learning disabilities. So we looked at ADHD. She's not in social work. She's in early childhood area.
I think he's in early childhood. That's why I said, you know. Yeah.
Okay. So the question is, could attention deficit hyperactivity disorder contribute to the lower educational attainment among survivors of abuse? So if you look at qualitative interviews, there's a lot of people talking about being hypervigilant. They said, you know, is Dad going to come home tonight and beat me up? I'm always alert, always watching things out of the corner of my eye. So algebra doesn't seem that major to focus on when I have this constant fear response about, am I going to be safe? Am I going to be able to keep my siblings safe? All of those issues. So it could be that people are being diagnosed that actually don't have ADHD but are presenting as though they do because of hypervigilance. Or I don't know what the story is, but we looked at, again, a Canadian data set, the 2005 data that was Manitoba, Saskatchewan. And in the general population, if you don't have ADD, ADHD, 7.2% report that they had been physically abused as a child, on average. If they have AD, if they report that they have been diagnosed by a health professional with ADD, ADHD, 30% basically say that they've been physically abused. Now, I know what you're thinking. We don't know which direction this association goes. Children who are exhibiting ADHD behaviors are harder children to parent. So also, there is a hereditary component. So if my child has ADHD, I might have ADHD, and I have some impulse control issues too that might result in abuse. But it could be that there's some direction the other way too, that the early adversity, you know, just think of second child syndrome, there's all kinds of other things that may have promoted ADHD. We don't know which direction it goes, but again, when I was talking about potential markers to trigger a regular screening, it seems to me if I have 30% of my population with any disorder, whether I know it's causal or not, I would use it as a screening tool, as a sort of a marker that I should be screening this population regularly. Does anyone know where this is? So, it's London. This is called Whitehall. So this is the Whitehall study. Sir Michael Marmot, he's Sir because of this study. He's an epidemiologist originally from Australia, trained in Berkeley, and then since the late 60s, early 70s or so, he's been working in England. And he's a social epidemiologist, and he was brought on to look at social aspects of heart disease in a big study that was done of civil servants. So he's looking at people who have regular, this is pre-Thatcher England, that had regular employment, huge amounts of job security. They weren't worried about housing over their head or food on the plate. Everybody was working. And the nice thing about, well, I don't know nice, but the nice thing for the study was that civil servants have ranks, and they're completely hierarchical. You're rank 1, rank 2, rank 3, A, B, C. You know exactly where the janitor is compared to the secretary, compared to the assistant deputy minister. There's all of these. And he found, remember we were talking about dose response, this stepwise response? He found for heart disease and for many other disorders, there was this perfect stepwise result about the higher you are in the status, the lower your disease. The lower you are, the more likely you are to die of almost anything, and certainly to contract almost everything. So it's a fascinating study. And most people said, wait a second, the lowest ranks smoke more, they drink more, that probably explains it. So he adjusted for it, and that did explain some of the variability, but there still was a stepwise response. Even if you had somebody who was a janitor who never smoked and never drank and was 50 years old, and you had the assistant deputy minister who never smoked and never drank at 50, there would be a difference in the risk or the prevalence of disease. So his research has really helped move forward the social determinants of health and the socioeconomic role. So that plays a major issue in what's going on with these kids coming out of these adverse households. They're just not necessarily being able to get to college and get through college. There's so many other things going on in their life, and there may not be the resources at home or the inclination to support them in that process. And again, we talked about marital dissolution being a risk factor for, or it's not exactly clear the association, but the association is clear, but the causal links aren't totally clear, but we are adjusting for those. Mental health, as we said, there's a huge literature on the association between childhood physical abuse, childhood sexual abuse, parental addictions, all of these risk factors, and depression, and an emerging literature on anxiety, which is a major factor, we think, in this. And each of these mental health outcomes have been associated with physical health conditions, which I'm not sure is as generally known. For example, if you have depression, your risk of heart disease goes up markedly. So the idea, one of the hypotheses is the pathway is through inflammation, that you have sort of a chronic inflammation kind of issue. So here's the Canadian Community Health Survey I've referred to. Most of my data I'm going to just report are from the 2005. It's a cross-sectional survey looking at health and social determinants. The response rates were extraordinarily good. This, of course, was pre the fiasco about the Statistics Canada and census. So this was not a census, but it was people phoning up and saying, Statistics Canada is phoning, would you like to respond? And 84% said yes. They weren't mandated to do it, but the response rate was phenomenal for a social science survey. So we can be pretty confident that what we find really exists, because it's not likely due to a selection bias in the sample. So the respondents were asked, while you were a child or a teenager living at home, were you ever physically abused by someone close to you? So you can see potentially this could be an older sibling, but the majority of cases we believe are probably a parent or step-parent. And as overall, about 6.9% reported they'd been physically abused. And then there was a whole list of chronic health conditions. So they said, have you been diagnosed by a health professional with any of the following long-term conditions that have lasted 6 months or more? So this is self-report of a medical diagnosis. The response, other literature says that's fairly good. It's not perfect. I would have loved to have the health records, but I would never get a representative community sample if I have that. So you have to take them all with a grain of salt. I'm only going to show you one graph so your eyes don't glaze over, but this is our first study that we published. I did it with, whoops, there's a miss. John Frank was also on this study. I don't know why it got missed off, but anyway, we published it in Cancer. So we said, if we just adjust for age, gender, and race, so in other words, if I have a female, white, 50-year-old, is the risk of cancer higher if they've been physically abused? And we found it was about 49% higher. That's quite substantial. And I said, okay, well, what happens if I adjust for other childhood stressors, parental addictions, parental divorce, parental long-term unemployment? Nothing happens. It stays the same. What happens if I adjust for smoking, drinking, inactivity, obesity? Each of these is highly associated both with childhood physical abuse and with cancer, but it doesn't explain the direct association. It doesn't attenuate the association at all. Then we looked at adult stressors. It's not totally fair. Marital status is in there as a stressor, but I couldn't find out exactly the right word for that. But also self-reported stress. So there's stress in their life. And then I fully adjusted for all of these, which it turns out to be 13 or 14 variables in there, and I get to 1.45. So 1.49 to 1.45 means it did not move at all. Mm-hmm. This association is not due to all the things I thought it was. It's probably due to stress. Because I had honestly thought that it would attenuate substantially by the time I put in socioeconomic condition. And Felidi's first work, he thought it was due to health behaviors. Of course, he's coming out of a work with obesity. He thought it was probably due to health behaviors. But it isn't, that doesn't explain the direct association. They're both important factors, but they're not, one isn't really the pathway through which cancer occurs for this population. Okay, so this is just putting it in words. When I adjusted just for age, gender, and race, I got 49%. When I adjusted for everything, I got it down to 45%. Oh, there. Oh, no, sorry. Cancer was just with Sarah. Sorry, the heart disease one was with John Frank. So he used to be head of the CIHR public health stream. So the age, gender, race for heart disease was, so just the simple adjustment, we had 1.57. It did come down, but not very much. It was about 45% higher risk. So spoiler alert, almost every disease I'm going to give you is somewhere between 35 and 60% higher odds after full adjustment. So this previous one was 45, this one's 45. Osteoarthritis. Again, one of the major chronic health conditions are going. It started out about twice the odds, 1.99, when I just adjusted for age, race, and socioeconomic status. When I adjusted for health behavior, obesity is a very big risk factor for osteoarthritis. I still have 56% left unexplained. Migraine. So we started out, we had about 77%. It came down to 36% once we adjusted for other issues, but still statistically significant. So I did this with Toby Baker, one of our MSW students, and Sarah Brennenstuhl. So we published it, and we thought, oh, what a novel finding, how interesting. And the exact same issue of headache, which is one of the big migraine journals, had a study from Taiwan looking at adolescents and finding the same association with migraine among adolescents, a large sample of adolescents. So this is really a fascinating field to be in right now, because literally every month new things are coming out. And if you are particularly interested in the sort of abuse literature, Harry Stein at Stanford runs a monthly sort of annotated bib. She pulls out all the literature and she publishes them monthly, and you can access them online. So you can just see the new literature coming out, and she has a repository of her old ones. So I highly recommend. Afterwards, I'll give you the link to it if you're interested. So peptic ulcers, okay. So it used to be thought, even when I was growing up and into the 1980s, it used to be thought that peptic ulcer was just stress related. And then they found out that H. pylori bacteria is associated with causing it. So there's a great quote from Robert Sapolsky about how all the internal medicine doctors are like, whew, don't have to talk about emotions anymore. But it turns out most of us actually carry H. pylori and do not have the disease. So it's an environment bacteria interaction like that. The stressors do seem to play a role. And we were looking at one particular stressor, in this case childhood physical abuse, and after full adjustments found about 68% higher risk. So that's one of the higher ones that we've been looking at. Thyroid disorders, we just published this a month or two ago, I think. This is with Farah Cow, who is an MSW student with us. Lori Yankura is an associate professor in Hawaii, and then Sarah Brennenstuhl as well. We found about 40% higher risk after we did all the adjustments. Again, this is for women, not for men. We don't know if it's hypo or hyperthyroid, but it seems to be very strong for women, not men. Of course, thyroid disorders are much more common in women than men, too, but it seemed that the association didn't even look like, even if we had more power, it would have been there for the males. By power, I mean sort of enough people in the sample in order to statistically see the difference. Now, these ones were where the highest associations are. So functional somatic syndromes are very common. These are disorders that when you look physiologically, you can't exactly figure out what it is. You're making the assessment because of the symptoms. They're very disabling, very costly disorders. So we looked at four. Chronic fatigue syndrome. And after full adjustment, we're still at twice the risk. We looked at fibromyalgia, which is a chronic pain disorder, 65% higher risk. We looked at multiple chemical sensitivities and found almost 3 times the risk. Now, I've now shown you 9 different disorders, and even after full adjustments with everything I could think of in the psychosocial, in demographic context, it doesn't adjust. It doesn't attenuate the relationship. This is fully attenuate. This is the one exception. So irritable bowel syndrome was associated with about 50% higher risk people who were physically, these are only women. Men, there was no association in any of these. So for women who were physically abused, they had about 50% higher risk of irritable bowel syndrome than women who were not abused. But when I adjusted for mental health, particularly depression, the association went away. So if women who were physically abused did not develop depression, they were not at greater risk of irritable bowel syndrome. It was the mixing of early adversity and subsequent depression that seemed to put people at the most vulnerable. So these studies all have limitations. I've highlighted some of those as we've gone along, so everything has to be taken with a grain of salt. We've self-report of a medical diagnosis rather than chart review, although our findings are somewhat similar to what Felitti came about when he had chart review. We have retrospective self-report of childhood physical abuse. And there's a potential for bias. Maybe if I'm ill, I look back at my childhood experiences differently. To me, though, I'm not quite clear why women would look at it differently in one type of disorder and men would look at it differently in another type of disorder. That doesn't seem to make sense. I would think it would always be with one gender showing that, or I don't see why you have one, you go one way and a different disease you go the other. The other piece is that other people have done studies looking at substantiated cases of childhood physical abuse and following them forward into adulthood. And then they go and ask them about their childhood experiences, and there was a strong tendency to underreport rather than to overreport. So we are vulnerable to bias, but there isn't a huge amount of evidence suggesting that. I think this is more of an issue with depression and anxiety and mental health outcomes, that the retrospective bias might be stronger than with physical health outcomes. But we don't know what we've got exactly. Again, we've got cross-sectional data, and so we don't know causal inferences. So when we're looking way back at the beginning, I was showing you 0 risk factors versus 3 risk factors. Well, I don't know when the child abuse happened. Did the child abuse happen before the parental addictions happened? Did it happen after the parental divorce? Was the parental divorce to keep the child safe because there was abuse? I mean, so we don't really know what order. There's always a problem with retrospective data collection. And in these particular data sets, we can't control for childhood socioeconomic status nor personality factors. And we're missing some risk factors, genetic factors, et cetera, for heart disease, although why those would be distributed in households with abuse and not others. But there's all kinds of other factors we can't really control for. So it may be it may be that I'm missing something key. And so we've tried to look at different data sets where we might be able to control some of these. So I said, well, where else can we go? And one of the situations I was very vulnerable to is what we were talking about earlier about childhood physical abuse not necessarily being a sole event, that there are physical abuse. There might be other stuff going on. And so reviewers were always saying, well, what about sexual abuse? What about verbal abuse? What about domestic violence? And I couldn't answer any of those 3 with the Canadian, because they didn't ask in the Canadian Community Health Survey that I was using. So the Centre for Disease Control does an annual survey called the Brief Risk Factor Surveillance System, which I will now call BRFSS because I can only remember it briefly as anything else. They ask 500,000 people a variety of basic questions, and each of the states has the option of paying more money to ask in questions. And so about 20,000 of them since 2010, 20,000 respondents, which are different states, but around 5 states at a time, 4 or 5 states, have asked questions about adverse childhood experiences that includes all of these items. So the smoking data I presented earlier was based on the 2010 BRFSS from the states. Again, it's a population-based study, so it's representative community sample. And we found sexual abuse. So this, I think, was the question that came up, how I looked at sexual abuse. So this case, we looked at sexual abuse and heart attacks. So these are people who reported that they had heart attacks and reported that they were sexually abused. And I was trying to get a clean picture of what the association is, because so many people who are sexually abused are also physically abused. So I removed anyone who reported that they were physically abused. So I have people who were not physically abused but were sexually abused. And against my hypothesis, I thought that if it was only going to be one gender, I thought it would be women, just because of my practice experience back in the 80s. I didn't actually have many male sexual abuse survivors. Even then, people weren't talking about that in the 1980s. So my experience was working with women, and the devastation that caused, and the cascade of repercussions throughout their life, I thought it'd be women. But we did not find an association between sexual abuse and heart attack in women. We found a huge association in men. Not double, triple. So triple the odds of heart attack compared to their peers who weren't sexually abused. So ex post facto, I go back and think, why would that be? Now remember, people don't get heart attacks until they're in their 60s and 70s. So these are people who were abused in their 1940s, 1950s, 1960s. these, in those eras, people were not bringing this forth. They're not seeking out help because it was a forbidden topic. There's a huge amount of homophobia. 98% of all abusers are male. So this is likely to be a homosexual abuse. So it could be just keeping it internally. It may be some of the issue. Again, this was done with Raluca Bajan. She was a master's student with us at the time. She's now a PhD student. John Hunter, who's gone on to do law now, and Tamara Grundlund, who was a master's student with us, and then Sarah, who was a doctoral student at the time. Well, and I've also started to look at parental addictions, and we're just getting work. We've started with the easiest one, which is depression, which is not surprisingly there's a large link, and we're just moving forward to look at parental addictions and health outcomes right now. I don't have any data to report. That's still underway. But we found that after full adjustment, they had about 69% higher odds. So women or men whose parents were addicted to drugs or alcohol while they were growing up were more likely to develop depression in adulthood. Again, Robin Katz, social work student with us, Vi Fan, Jessica Liddycoat, all MSW students, and Sarah did this with me. This one's a little more controversial. There is a literature about parental divorce and premature mortality. So this is a fascinating study done out of Stanford called the Terman Gifted Children Study. And these children have been, they're now dead. It started in 1921. I don't think there's hardly any alive, if any, because they were already 11 by 1921. And they were called the termites, actually, because they followed them. And so he was one of the designers of the Stanford Binet IQ test, and he thought IQ was going to be everything. So he did a survey in California of all of these incredibly bright kids. I think he had an IQ of over 130 or 140 to get in, and he followed them for the rest of their lives. And somebody, obviously he's no longer with us, Terman, but other researchers, Martin and colleagues, pulled up the data and looked at long-term mortality. And one of the biggest predictors of whether you died early was whether your parents are divorced. And they died on average 4.5 years earlier. And some of that association was independent of their childhood personality, but it was partially mediated by those health behaviors like smoking and own divorce and lower education level. They tended to not be able to complete university, and they didn't go on the same trajectory. This Terman study is fascinating because he actually he thought he was going to create he was going to be able to assess all the new Nobel laureates. And he did interview one person who became a Nobel laureate, but they didn't make the cut of the 130, so they didn't get in the study. So none of theirs actually it became very clear that being very brilliant is necessary but not sufficient. Anyway, so there's a fascinating book on this, on all of his studies that have come out, and it's a very interesting read, actually. So Alameda County study was started in the mid-60s from the social epidemiologist at Berkeley. Alameda County is the county where Oakland is, on the East Bay of San Francisco. And these people were born sort of after 1924. They're now quite old. And so they're looking at death under age 75, and found that parental divorce was associated with 47% higher odds of death. And when you adjust for education and social networks and depression and smoking, it was 27%. But if you looked only at certain types of deaths, particularly cardiovascular deaths, it was quite a bit higher. Now remember, these parents would have divorced in both studies, 1920s, 1930s, 1940s. These were very rare events, and the stigma associated with were quite high. But there has been some study in Europe as well showing about a link with cancer and parental divorce. We did an association, we looked at stroke as our outcome, again with this was with Canadian data. Angela Dalton, the co-author, was an MSW study with us, a student with us. She's now working back in PEI. So we found a threefold risk. Again, these are really big numbers. In social sciences, we don't get threefold risks very often. So a threefold risk of stroke for males, again males, poor males, whose parents divorced. There was no association for females. Of course, stroke is more prevalent in males. At the people who are answering our surveys, stroke's more prevalent in males. But this was interesting because I had a big enough sample that we could exclude anyone who, this is American data set. We excluded anyone who reported that they were physically abused, sexually abused, or their parents were addicted to drugs and alcohol, or that there was domestic violence. So these are relatively clean divorces. They may be acrimonious as all get out, but there's no violence in the household to the child or between the parents. And we still found this threefold risk.
Esme, did you ask the respondents if they were divorced?
None of these are all what we call secondary data that they were asked. I would have that information if they were currently divorced. I wouldn't know if they were divorced and remarried. I wouldn't know their marital history, but I would know if I would know that. And I adjusted for current marital status as a predictor of stroke because it's associated with stroke, and it didn't attenuate. This threefold risk
Especially for men, right?
This is a threefold risk after I've adjusted for everything else, including current marital status. But I wouldn't have known if they married, divorced, and remarried, they'd count as married in this particular study, okay? Because I don't know their history. So we're trying to figure out exactly why that might be so. We think that men's help-seeking behavior, boys' help-seeking behavior, they may be less likely to talk to others or seek help or not to pathologize. We're just trying to figure out why this might be so. And maybe dads are, in this era, remember, by the time you get heart disease, you're still old, or stroke, you're still old. So these are people whose parents divorced when it was relatively atypical. So there might be stigma attached to it, but I would have thought there would be stigma to the women to the same extent as the men. So there must be something else going on with the men. And there is some literature that good fathering can help boys control their emotions and calm their fight or flight response and those types of things. So it may be, in this era, it was quite typical that divorced fathers did not have a huge amount of contact with their children. And it's very different than it is nowadays. So it may have something to do with that. We don't know exactly what it has to do, and we have a variety of different studies going on that we haven't. We also found suicidal risk much higher in men. It wasn't a risk factor for women, but suicidal ideation was much higher in boys whose parents are divorced. So that's what I found. So I found that there is an association, and it's not explained by all my favorite candidates, whether that's health behaviors or socioeconomic. So this is where we started. You kind of gave the spoiler alert at the beginning, which was what's going on that keeps this association. How come it isn't attenuated completely? Why doesn't it just disappear? I mean, it still would be of value to know that there is an association between childhood abuse and heart disease, but if we understood it was completely through health behaviors, then your intervention would look like you'd just be intervening on health behaviors, right? So Clyde Hertzman is this thoughtful, interesting scholar at UBC who's come up with this concept he calls biological embedding, which is his explanation about how does early adversity get under the skin. And he talks a lot. His early adversity he looks at primarily is poverty, and how does poverty get under the skin and cause these long-term health outcomes. So he looks at the hypothalamus pituitary adrenal axis, which we call the HPA axis, and he talks about hypervigilance, which I mentioned briefly, that just needing to be aware. Well, that was really protective when you were a child, and you're like this woman was saying, just I needed to be watching his face, finding out. And in fact, they find that kids who are abused are very good assessors of judging fear behavior and threatening behavior. If you flash up pictures, they're better than the average person because it's very protective of them to do that. But if they have this constant response to every stress they meet for the rest of their life, even when they're in a safe environment, that results in dysfunctions in cortisol production. That's the fight or flight hormone is up through the roof, and chronic inflammation. So inflammation's a good thing if you're expecting to be attacked on the Serengeti and you want to be able to clot up your wounds. But if you have it going continuously, if you're reacting to psychosocial stressors, that takes a toll on a variety of different health outcomes. There's also some really interesting work coming out, particularly with this group in London. Caspi is one of the key people in that, about gene by environment interactions. So when environmental experience really moderates the effect of a person's genotype on the physical or mental health outcomes. So it's not vulnerable genes, not vulnerable genes. It's genes in the context of the environment. And so the first work comes out of Steve Suomi's research on rhesus monkeys. And he found a special polymorphism, which you can think of as a variation in a gene. So there's a gene and it comes in short and long variations. We could call alleles kind of variations. And so if you've got the short variation, monkeys are more likely to have poor control of aggression, depression, anxiety, high reactivity, that startle response kind of thing, and increased alcohol consumption. They make these poor animals addicted to drugs and alcohol. So they give them the happy hour, and they press a button and they drink. And most monkeys will have a bit and that'll be it. But these guys will just drink till they drop. Anyway, if these short allele monkeys, so we call these sort of vulnerable monkeys, if they're raised in pure raising context, so they're given adequate food and nutrition, but the pictures are so distressing, I wouldn't let my daughter, who was putting these pictures up for me, put one on, but they actually put them in an enclosement with other monkeys their own age. So they don't really have any mothering, they have each other, but they don't have good quality mothering because they're just taking care of each other. They do very poorly. But if they're cross-fostered to an exemplary mother who's very attentive to their needs, they do fine. In fact, they even do a little bit better than the long allele version. So Boyce and Ellis, let's see, Bruce Ellis is down in somewhere in the south, maybe Arizona, and Tom Boyce is at UBC now, used to be at Berkeley. They came up with the idea of dandelion or orchid children. Has anyone heard about this idea? Oh, it resonates.
This was covered recently.
Yeah, it's brilliant. Yeah, they've done very. So basically, if you have these vulnerability, what used to be vulnerability alleles, they're vulnerability because we only looked at the negative end of the spectrum. We never looked at the positive end of the spectrum. And the idea is, why would these alleles be so prevalent if in an evolutionary perspective they're a disadvantage? Because you'd normally expect people, it would be worn out of your system because you wouldn't procreate at the same rate. So there must be some advantage. And the idea is, if you might put most of your eggs in a safe basket, we call that the dandelion basket. They'll grow fine if it's a bad environment, fine if it's a good environment with respect to nurturing. But you want to have a few riskier offspring that might explode and not do well in a bad environment, but they could become an orchid in a good environment. And if any of you have had orchids and overwatered them, you realize they are quite sensitive. Because I love orchids and I've killed lots of them in my life. But it's really, instead of just being vulnerability, they're really genetic sensitivity to context. And they've started to do some fascinating human studies it's called Dunedin study in New Zealand. So Dunedin is a town in southern New Zealand, a university town of about 100,000. And I think, I've forgotten what year the kids were born, maybe 1972 or something like that. They put every kid in this town into the study, and they did all kinds of surveys. And now they're adults, and they've been following them up. And they found, then they've also taken blood work, and they find that they've got this short allele we just talked about. It's associated with depression, chronic inflammation. They said these kids are too young when they did the chronic inflammation when they're in their 20s. You don't have diseases by your 20s, but you can look at your biomarkers, and about 20% of the inflammation was explained by their early childhood experiences. So they have chronically high inflammation. And these other metabolic markers of increased risk, only if they've been abused in childhood or experienced another serious stressors. but the long allele, those are the dandelion kids. They seemed to be resilient, even if they had bad early experiences. They didn't seem to be have hard outcomes. So, how many people here are social workers or work in a clinical practice? Okay, so you'll know that you see a household, and there's two kids that lived in equally chaotic, and one kid does okay, and the other kid crashes and burns, and their home environment's not that different. And I've always wondered, why is that so? And there's a possibility, not to say it's predetermined, but there's a possibility that there's a physiological risk here. And they've done lab studies of people with short versus long, and they show greater stress response in the lab. So I forget what they give them, but maybe a public speaking assignment, and they just see what happens to your cortisol, et cetera, if you've got the small versus long, short versus long allele. And they're more likely to develop post-traumatic stress disorder and anxiety. I don't have data on post-traumatic stress. I'm hoping to have it in a new data set coming out, because that may be one of the links, that it's through post-traumatic stress that you see some of these health outcomes. There was an fMRI, which is an imaging study of the brain of 92 people, and it showed that the amygdala, which is your fear response center, hyper responds to environmental threats if you have the short allele. And these are not people who were necessarily abused. This is just people, general people. And so there's still a huge debate on this, but this is the news is not in yet, but this is something to keep an eye out. I'm just running my time. Oh, am I beyond my time? Because this is a fascinating study I'll refer you to. Yeah, is it? I can't even see. 5 minutes after 1? Okay. All right. So this is Mike Ander and colleagues in 2006 did this fascinating study. Not a study, but sort of an overview of what kind of dysfunctions they see, areas of dysfunction that they see in children who have been through serious adversity, now adults, and where it might reflect in their brain, neurobiological changes. And this is where a lot of the work is going on. So they say, for example, anxiety and panic and depressed affect and hallucinations and substance abuse. You probably see that repeated stress and childhood trauma is associated with hippocampus, amygdala, the fear response center, and the medial prefrontal cortex atrophy and dysfunction, and that mediates anxiety and mood. Use addictive behavior, locus coeruleus, and norepinephrine activity. I can't say any of these words, but those activity are decreased by heroin and alcohol. They're more soothed. So this has got a wonderful workup, and I really recommend you going through the paper if you're interested in the neurological implications of adversity. So I've got all these other questions. What promotes resiliency? How do gender differences play out? What do prospective studies tell us? Because I'm doing retrospective here. What role does PTSD play? Do sleep disorders attenuate the relationship? Because sleep is a major issue in most of these health outcomes and has been understudied to date. And what role does this biological implanting play? And this is sort of my take home. We know already trauma-focused cognitive behavioral therapy makes a huge difference with post-traumatic stress disorder. This is a program that's 12 weeks, 1 hour a week, can be provided in a group setting, and there's free training for health professionals online that takes 10 to 15 hours to do. So I'm thinking, why isn't every substantiated case of childhood sexual and physical abuse getting a referral? Typically, if you're self-harming behavior, you're not going to school. If you're showing immediate real risks, you'll get a referral, but you won't get a referral if you're the good kid that's doing fine. And I'm just worried that those are the kids that may be in my study 60 years from now. And if we don't know for sure that an intervention like this is going to make them healthy, or less likely to get heart disease down the line, but we know it's very effective for pulling down PTSD. So I think we've already got enough of a reason to provide that. A new project I have going on, I've spent my sabbatical in Cambridge, and I was training into London to work with the 1946 birth cohort. So this is a sample of about 4,000 people born in Britain in Bye Rachel. Thanks for coming.
Thank you.
Born in 1946, and they've been followed 22 times ever. Since then, they're in their late 60s now. So I've been working with Diana Koo, who runs that research project, and now I have some prospective information on their childhood income, and and their home visitors at age 40, like home visiting nurses assessing what the housing quality was like and things like that. So and it's been linked to National Data Registry. So I think I've got some better data to start to do some exploration on some of these outcomes. It doesn't have wonderful data on early adversity with respect to abuse, so we're a little stuck. But the 1958 cohort, which I wasn't working with, has already started to publish some health outcomes. So many thanks to many of my students, and thank you for coming. Did you have a comment you wanted to read first, or did you have a comment?
There are two. Oh, Nat was saying it's a great presentation. Could he get copies of the slides?
Certainly.
Okay. And another one saying awesome, interesting, and thank you.
Thank you. My little cheering squad. Thank you, Gaycrest. There we go. Great. You had a point.
Thank you so much. That was very informative. I'm wondering, there was a couple points referring to inflammation, cortisol production, which are in some of the literature indicate diabetes in relation to diabetes. Have you come across anything on diabetes in relation to abuse?
You know what? I have a study underway, and I don't know what the results are yet, but I'll keep you posted. You can email me, okay? I think it'll probably be 6 months before I know. Okay? Thanks.
I'm just curious about how physical abuse is defined or captured in terms of intensity. Was it people who got hit a few times? So how was that sort of captured or defined?
Oh, absolutely. Yeah, the question's there, but it's not a great question. It's just a one-off question which says, okay, just let me just go back. How do I get out of this escape? Just a second. It doesn't have intensity, and in fact, the Ontario researchers have come up with, Harriet McMillan's group have come up with a much better measure with the intensity and number of abuses. But what amazed me was such a rough tool, and I could still find this association. Let me see if I can find it. Oh, okay. While you were a child or teenager living at home, were you ever physically abused by someone close to you? That's it. And it could have been daily, or it could have been a once-off. Well, what's amazing is I'm getting threefold risks from some of these, right? So I think it would, and in fact, some new data coming out is going to be able for me to figure out. They ask whether it's up to 10 times, or so I'll be able to get a dose response. One would think there'd be a dose response, but you're right. We don't know anything about that.
Yeah, it just might translate into some of the health outcomes later if you were abused for many years, hospitalized because of the abuse. And see what kind of effects you might get.
Oh yeah, so some of you're saying, particularly if the level of abuse was such that it was hospitalization. I don't know if you know, but the vast majority of substantiated child abuse cases in Ontario are not sufficient to send you to hospital. So I think it's maybe under 5% or 10% that actually send you to hospital. So we don't know, but you're saying that they may in fact have had shaken baby syndrome and all kinds of things that would be directly associated with these health outcomes rather than mediated through stress or something like that. It's a good point. It's a good point. I wish I could be able to address that. So, yeah, go ahead.
Could I just, when you were speaking about all of the measures, I'd really like to see something on neglect, because that's what I see is neglect. And it does make a huge difference overall. My daughter wasn't here, she worked with Youth at Risk, and she said, could you ask about personality disorders? Have you done any research on any of this creating personality disorders, multiple personalities, and said especially the one, I've written it down someplace, but borderline personality.
Yeah, I don't have data on that. I hopefully will within the next 5 years. And there's a substantial literature on childhood sexual abuse and some of these disorders, but in smaller clinical samples. It'd be really interesting to be able to show it in a population-based study. As you can see, I focus mostly on physical health outcomes just because they haven't been attended to, or at least adequately in the literature. But there's certainly a whole field that could be explored.
The other thing too, when you're speaking about men and women and the abuse, I wrote down, women, the only way they get away from it is they leave, whereas young boys become big and men, and they stop it usually physically and say, if you touch me, I'm going to get back at you. Whereas women don't do that. And I just wonder if the men, because in some way they can control the situation at some age, okay, as opposed to women who do not control the situation, mainly just leave, or that makes a difference. I don't know.
Oh,
That's a
okay,
thought
so
I was
it's
having.
something to think of. So
Yeah.
just for the audience at home who may not hear that, it's just what role is played by the different ways that men and women may, young boys and
Stop it.
girls
Stop
may intervene to stop the abuse at home. Yeah, I think there's a possibility. I still haven't quite figured out why some diseases go one, or
Yeah.
what
With the
gender,
heart.
one gender is vulnerable to one disease and one's another. One idea that we're thinking about, for example, with heart disease and stroke, is that chronic inflammation pulls down males' testosterone. And low testosterone may put people at risk for some of these heart disease and circulation problems, but we don't know exactly.
Okay.
I don't have any of the, I don't have any physiological measures. I'm just guessing after the fact. Yeah. Any other questions?
Sorry,
Thanks.
I have one last comment.
Yes.
Terry says, as long ago as 1889, Jen Hindman wrote in Just Before Dawn that frequency or even the level of violence in sexual assault did not have as strong a correlation to the degree of trauma experienced as adults as about 15 other factors, which she explained quite explicitly in her book.
In what was the year?
1989.
Oh, great. Well, I haven't read the book, but thank you for the reference. I'll look it up.
You can give us a site for that.
Sorry, which one?
Stein?
Oh, Harise Stein. So it's Harise, Harise, Stein, Stein, and it's at Stanford. I wonder if I've got my email. You can email me if you can't find it. It's something like abuse research or something along that line. I don't know how to get out of this, but if you try to just Google it, you might be able to find that. But she's been doing it for about the last 2 years, and every month it's just a burgeoning literature. It's quite fascinating what's coming out. Any other comments or questions?
If no one else, I just want a second chance.
Yeah.
Any other hopes in addressing these issues besides behavioral?
I mean, prevention would be great.
Yeah.
I mean, no child should ever have to go through any of this. So I think, I don't know exactly. As I said, I started as a gerontologist, and I'm down in this, down way with the little ones. But I would...
You work in gerontology, so it's the other way around.
Yeah. I would love to know more effectively what could be a really effective intervention to prevent all of these abuses. And the greater the strength of the social safety net and intervening at birth, and I mean, there's all kinds of issues. But trauma-focused CBT, just the literature's so strong on it. I know that literature. There may be other interventions that are also effective, but it just appalls me that every child with substantiated abuse is not getting an intervention, whether they look symptomatic or not. Right? Okay.
Thank you
for
Esme.
coming.